Okay. All right. So mood disorders are also, we call them affective disorders. So in the clinical setting, you might hear those terms used interchangeably. Mood disorders are just considered alterations in our emotions that can be caused by either a state of depression or a state of mania or a combination of both. So some patients will have depression and mania together, or they can just be isolated. Mood disorders will interfere with our life. They can cause a patient to experience sadness long-term, depending on the circumstance in which it originates. It could just also be short-term. It can cause agitation. It can cause periods of elation. And then, of course, depression, which is what we call that long-term sadness. These patients also experience a lot of self-doubt. They have a lot of self-esteem issues. It can cause anger. It can cause a complete alteration in their life activities. It causes problems with their family members, with their friends. It keeps them from being able to be productive members of society. Sometimes it interferes with their obligation, with their occupation. So being able to go to work every day and just be a contributing member of society. So when we talk about mood disorders, so mood disorders have been around for many, many, many years throughout history. Archaeologists have discovered ancient skulls that they found from years and years and years ago. Those skulls were discovered to have holes drilled in the heads, and it's believed that back then they would drill holes in the head to let out these evil spirits. And then with our Babylonians and the ancient Hebrews, they believed that the overwhelming sadness was sent to people through God or other divine beings. So there's a lot of different thought processes on what they thought about mood disorders years ago. Up until the mid-1950s, which is very recently, there was no treatment for mood disorders. So people suffered with mania and severe depression. They suffered through those different varying moods that they have going between the depression and the mania, thinking that they were weak, and they were just left to succumb to these devastating symptoms. They didn't think that they were ever going to actually get any help. So mood disorders, we see these commonly associated with patients who are at associated risks for committing suicide. The risk is much, much higher for these individuals. Depression is one of the most important risk factors that we see. Patients with schizophrenia, substance use disorders, those antisocial and borderline personality disorders, and panic disorders are also at an increased risk for suicide and suicide attempts. The primary mood disorders that we see are major depressive disorder and bipolar disorder, which these were formerly called manic depressive illnesses. So some of your older nurses in the clinical setting, that may be what they still refer to them as. So major depressive disorders, these are illnesses that last at least 2 weeks, usually longer. So anything less than 2 weeks, we would not consider a major depressive disorder. This is where a patient experiences a depressed mood or a loss in pleasure in all nearly activities. So this is your patient who used to like to get together with her girlfriends and go to dinner once a month. It doesn't do that anymore. This is the husband who used to play golf avidly every Sunday for years, and now he doesn't do that anymore. Things that they used to enjoy now become a burden to them. They don't have the energy to do it. They're exhausted mentally. That carries over into them physically. So when you notice people that start to lose an interest in things that they that they used to enjoy doing for years, this is a good sign that they probably have this major depressive disorders. So some of the symptoms that they may exhibit, so these are a lot of the symptoms. It doesn't mean that every person will experience all of these symptoms. So you can see a change in eating habits. It can be both spectrums. So maybe they just, some people when they're depressed, they don't have any appetite at all. Some people will do the opposite. They will just eat to comfort themselves. So a lack of appetite or a bigger appetite. So we could see unplanned weight loss or weight gain. Some patients may complain that they get too much sleep. They can't stop sleeping. They can sleep for 12, 15 hours a day and they're still exhausted. Or the opposite end of the spectrum. They're not hardly getting any sleep. They have trouble falling asleep. They have trouble staying asleep. They're only getting 2 to 3 hours sleep a night. These patients will have trouble concentrating. That could also be due to the depression, but then also the fact that they don't have any sleep. They have trouble with just regular, common decision-making, problem-solving abilities. They ultimately will have issues with just being able to cope with daily life. So getting up and getting a shower, cooking food for yourself, doing things around the house, washing dishes. All these little tasks that seem little to us become very, very overwhelming. They start to feel worthless. They think that they can't really see past the situation that they're in, so they feel very hopeless. They can't really rationalize that this is just a small part of time for them, that things will eventually get better. Then they start to have guilt because maybe they're not doing well at work. Maybe they're not living up to their employer's expectations. Maybe it's a husband who's married and he's not pulling his weight at home and everything's falling on his wife and he's not helping with the kids. So there's a lot that plays into that, which causes these feelings of guilt. Then they become desperate because they really don't know where to turn. So then that's where they start with these thoughts of death or suicide. They will also complain of overwhelming fatigue, and they will have rumination with pessimistic thinking with no hope of improvement. So these patients are not really capable of seeing past, like I said, that this is just, a small period of time. If I go to a therapist and I start on medication, I know things are going to get better. They don't feel like that, which explains why their only option for some people is to commit suicide, because they can't see a time in their life where it's going to be better. And they are so tired of feeling like this, being a letdown to people, not being able to perform at work and so on. They get tired of that, that weighted down feeling that they have. So obviously this will cause a significant amount of distress or impairment in their social relationships, their occupational relationships, and all other areas of functioning. Then we have bipolar disorder. So bipolar disorder is further broken down into bipolar 1 and bipolar 2. So bipolar disorder is when a person's mood fluctuates from extremes of mania to depression. Bipolar 1 is considered for a patient who has one or more manic or mixed episodes, usually accompanied by major depressive episodes. Bipolar 2 is one or more major depressive episodes accompanied by at least one hypomanic episode. So we're going to talk about we're going to go into more detail about bipolar 1 and 2 and then those hypomanic episodes. So mania is going to be where their mood is abnormally or persistently elevated. We say elevated, expansive, or irritable. So usually these periods of mania last at least a week, sometimes more for some people. What we will see with this mania is that their self-esteem is going to be highly inflated, or grandiosity. So they're going to think that they're the best of the best. They can do no wrong. They think that they have abilities that they really don't have. They think very, very highly of themselves. They don't sleep a lot, so they can go days without sleeping, and it never even occurs to them that they need sleep at all. They're just like on this high, and they're just going. So they will also present with something called excessive or pressured speech. So pressured speech is where when they're talking, their speech is very unrelenting, it's very rapid, and they talk loud without pauses. So they'll just go. They don't even take a breath in between sentences. They will also experience flight of ideas, which is, I think, what we've talked about before, which their thoughts are racing. They're not always connected with their thoughts. They're going to be very distracted. You're going to see increased activity or psychomotor agitation. excessive involvement in pleasure-seeking or risk-taking activities with a high potential for painful consequences. So unprotected sex, sex with multiple people, no regard for the speed when they're driving, 100 miles an hour and a 25, things like that, risk-taking activities. All right. Their mood may be excessively cheerful. They would be extra enthusiastic or expansive, or they may even present as a little irritable. They often deny that they have any problems at all. They don't think that there's anything wrong in their life. So these people place blame on others for any type of issues that they have in their life, anything that they're dealing with. So if they're having problems with a couple of her girlfriends, she's going to blame the problems on her girlfriends instead of her. It's not her issues, it's their issues. Same thing with employers. These people are always going to be saying, my employer is terrible. He does X, Y, and Z to me. They never have any accountability of their own. It is possible that sometimes during an extreme manic episode, these patients can also have delusions and hallucinations. So then hypomania. So this obviously is the complete opposite. So it's period of abnormally or persistent elevated, expansive, or irritable mood, and some other mild symptoms of mania. So it's not actually the opposite. It's just a kind of like a step down from the mania that we see. It's on a lesser scale. So they still have these manic events, but it doesn't impair their ability to function. Sometimes they can be quite productive. And then we don't see any psychotic features, any type of delusions or hallucinations. So kind of like the mania, but a little bit less. Everybody's getting thrown out tonight for some reason. So there's some other categories of mood disorders that you guys should know about. So we have dysmorphic disorder, which is a chronic persistent mood disturbance, which would be characterized by insomnia, a loss of appetite. They'll report that they don't really have any energy. They also have a low self-esteem. They may have trouble concentrating. They're going to report that they feel sad most of the time, helpless, but these symptoms are a little bit milder than we would see with depression. Then we have cyclothymic disorder. This is characterized by mild mood swings between hypomania and depression without a loss of any social or occupational functioning. We have substance-induced depressive or bipolar disorder. So this is a disturbance in their mood that is directly related to the ingestion of substances. So we're talking alcohol, illegal drugs, or it could be like pills or other type of toxins. And then we have non-suicidal self-injury. So these are patients who deliberately injure themselves. So by intentionally cutting themselves, burning themselves, scraping, hitting themselves, or if they have a wound somewhere, they will keep at that wound, healing with, messing with the ability for it to be able to heal. So if they have an open wound, they might just go in and pick it all the time, pick the scab off, which would cause more bleeding and which would inhibit that wound process from furthering along. When they hurt themselves, it helps them to alleviate some of the negative emotions that they have. Some people also view it as a sign of self-punishment. They're punishing themselves for something. They kind of feel like they deserve it. Some people do it to seek attention so that people notice it and will pay attention to them. And then some do it to escape a situation or a responsibility. So sometimes if they take and they cut themselves, the pain that they feel temporarily makes them focus on that pain instead of the pain that they feel mentally. So there's a lot of different reasons why people self-injure themselves. All right, then we have seasonal affective disorder. So we have winter depression, which is fall onset, or we have spring onset, which is less common. Winter depression is the major one that we see. So this is where patients will report that they will just want to sleep all the time. They have an increased appetite. They crave all those carbs. They're going to see a weight gain. They have issues relating or dealing with other people, maybe people that they work with or family members. They feel like they're all the time very, very irritable. Some people complain of a heaviness in their extremities. So this usually starts in late autumn, so sometime in October, and usually it's over in, I don't know, the middle of March, early April, once we start to see that the daytime stays later, longer, and we start to have nicer weather. And then we have spring onset, which is less common. Some patients that experience that will report that they have trouble sleeping, they'll have weight loss, poor appetite that lasts from late spring to early summer until early fall. And then these patients, you can use light therapy for these patients to help them. Oops, where was I? All right, postpartum blues, depression, psychosis, or premenstrual dysphoric disorder. So these are mild, predictable mood disturbances that occur usually in the first several days after a delivery of a baby. Postpartum blues and depression and psychosis, that can last about anywhere from the first couple of days up until sometimes a year or so after delivering. Symptoms include this labile mood. They might have crying spells, periods of sadness, insomnia, trouble sleeping, and some of them actually also report anxiety. So we have biological theories that shed some light on why we have mood disorders. So recent research does focus on chemical biologic imbalances as the cause. Oh, I think Lucy was just trying to get in, but now she's gone. Oh, there she is. All right. So psychosocial stressors and interpersonal events appear to trigger certain physiological and chemical changes in our brain, which will alter the balance of the neurotransmitters that we have. So genetic theories, that's one of our biologic theories. So it is believed that first-degree relatives who are twice the risk for developing depression, first-degree relatives of people with bipolar disorder have a 7-fold risk for developing bipolar disorder. Those identical twins, if both twins have a mood disorder, they're 2 to 4 times higher of, they are at 2 to 4 times higher risk than that of developing a mood disorder compared to those fraternal twins. Then we have neurochemical theories and neuroendocrine theories. So neuroendocrine theories, this is where they believe serotonin, norepinephrine, and possibly on some level, acetylcholine and dopamine will play a part in the development of these mood disorders. So serotonin and norepinephrine are the 2 major biogenic amines that we see associated with mood disorders. Deficits of serotonin levels are found in patients who suffer with depression. Norepinephrine levels may be deficient in depression and increased in patients that we see that experience mania. Cholinergic drugs that alter mood, sleep, and neuroendocrine function, and electroencephalographic pattern. So we know that some of the Parkinson drugs, those anticholinergics, we see the effect that they have on patients. So those cholinergic drugs will have the opposite effect. Acetylcholine does seem to be implicated on some level in depression and mania. To what level, we don't exactly know. There's a lot of studies that are going on with that now, so they don't know everything. It's just kind of something new that they're starting to look at and make those connections. We know that our hormones also have something to do with our with causing mood disorders. So people who have thyroid, adrenal, parathyroid, and pituitary gland disorders are at a higher risk for developing mood disorders. And then also glucocorticoid activity. Whenever our body is under stress, it will secrete higher levels of cortisol. So we see this in patients who have depression. About 40% of them will present with these higher levels of glucosteroids in their system. We also have psychodynamic theories. So these are theories about the cause of mood disorders that seem to blame the victim and his or her family. So we see self-deprecation. This is going to be related to either a real or a perceived loss. So a feeling abandoned by the loss, people are then angry while both loving and hating the lost object. We see ideal ego. So this is a person's ego or their self aspires to be ideal. So they want to be good. They want to be loving. They want to be superior or strong. And that to be loved and worthy, one must achieve certain high standards to get to that stage. Depression will result when the person is not able to achieve those ideals all the time on a consistent basis. Sometimes we see mania as a defense against underlying depression. So the ID will take over the ego and act as an undisciplined being or a child. Depression as reaction to life experience. So sometimes we know that if we experience a traumatic event or some type of stressor in our life, depression can occur as a result of that. And then rejecting or unloving parents. So patients are prone to feelings of insecurity and loneliness, making them susceptible to depression and helplessness if in their life growing up, they had parents that did not show them the amount of love that they needed, or they rejected them on some type of a level and weren't able to really build that good bond with their parents. And then we have cognitive distortions. These are early experiences that shape our distorted ways of thinking about ourselves, about the world, and our future. These distortions involve magnification of negative events, trails and expectations, and simultaneous minimization of anything positive. So there are other behaviors that are considered age appropriate that can mask depression. So children with depression often seem cranky. It doesn't always present as depression. They may just seem like they're cranky all the time. They may report that they have a phobia of school. They don't want to go to school. They just want to stay home. We might see hyperactivity in some children. It also can present through learning disorders. So if we see children that have failing grades and they're unable to learn like they used to, that could be a sign of depression. And then antisocial behaviors. So not wanting to join any school sports, not really having, a lot of friends, not doing extracurricular activities, going out with friends, things that normal children should do, playing in the neighborhood, that kind of stuff. Adolescents, they may be involved with substance abuse. They may join gangs, participate in risky behaviors. They might even drop out of school. Adults, they may partake in substance abuse. They might have eating disorders or compulsive behaviors. And then sometimes we'll see that patients will present with somatic complaints. So they actually have physiological ailments. So some people will report backaches, headaches, heart problems, chest pains, shortness of breath, things like that can be a sign of depression. And then once they start taking their depression medication, these side effects will eliminate, they'll go away. So normally what happens is if you see patients in the hospital repeatedly or in the primary care setting for these physical ailments and you do a series of tests and you really can't find anything wrong, that's when the care provider will start to look outside of the box and start thinking about mental health issues instead of physical issues. And we know that depression can vary among cultures and be more apparent in cultures that avoid verbalizing emotions because they tend to keep things in and not really talk about things. So major depressive disorder, like we said, is an untreated episode of depression that can last weeks, months, or years. It usually involves 2 weeks or more of a sad mood or lack of interest in life activities. At least 4 other symptoms of depression, such as anhedonia, which is the ability for someone to experience pleasure. So we want to see either that or a change in weight, difficulty with sleep, a change in their energy, their concentration, their ability to make decisions, their self-esteem, and their goals. Major depressive disorder is twice as common in women and has a 1.5 to 3 times greater incidence in first-degree relatives than in the general population. There's an incidence of depression decreases with age in women, but it's just the opposite with men. So as men get older, they have an increased rate of developing this major depressive disorder. So the clinical onset, it can last for a few weeks, 2 months, or even years. Major episodes are clear in about 6 months for most people. Approximately 20% of the population will develop a chronic form of depression. 50 to 60% of those people will suffer reoccurrence, so it's going to happen again in their lifetime. And depressive symptoms can vary from mild to severe. And then usually what we see, in not all cases, but in some cases, that severe depression will have those psychotic features. So researchers believe, like we said a couple slides back, that certain levels of neurotransmitters, especially norepinephrine and serotonin, are decreased in patients that we see that suffer from depression. So depression will result if too few of those neurotransmitters are released. So some of the medications that we can use, you should go to these tables that I have listed here. So you should look at these medications and read those charts. So we can give selective serotonin reuptake inhibitors, that's our SSRIs. We can give our TCAs, that's our tricyclic antidepressants. We can give our atypical antidepressants, and then our MAOI antidepressants. So 2 major things we know can happen as a side effect of these medications. Our patients can experience a hypertensive crisis, which, if you remember back from a couple weeks ago, is a life-threatening condition that can result when a client takes MAOIs and they ingest tyramine-containing foods. If you want to refresh your memory on that, if you go back to chapter 2, box 2.1, that'll give you some information about that. So tyramine-containing foods, fluids, or other medications. So these patients would present with a severe headache, obviously hypertension. They can complain of nausea, vomiting, chills, sweating, restlessness, nuchal rigidity, dilated pupils, fever, and motor agitation. That these symptoms are all going to lead to hyperprexia, which will cause cerebral hemorrhage and can also cause death. Usually once these patients take that MOI and take any type of food or medication or liquid that contains tyramine, it's going to produce this reaction within about 20 to 60 minutes after ingestion. So that's the period that you would want to watch. They can also develop serotonin syndrome. This occurs when there is an inadequate washout period between taking MAOIs and SSOIs, or when MAOIs are combined with meperidine. So if you are going to switch a patient from an MAOI to an SSRI, they don't just do it with serotonin syndrome is caused by that interaction, the MAOIs and the serotonins. But typically with all of the medications that we give, if we have a patient on an MAOI and it doesn't work and we're going to switch them to something else, you always want to wean them off of it and then give an acceptable amount of period between ending that medication and starting the new one, so that there's no overlap in the medication that can cause any of these symptoms. But the serotonin syndrome is definitely something that we see when that period isn't adhered to between the change of the MAOIs and the SSRIs. So these patients can present with a change in mental state. They can be confused, they can be agitated, they may suffer with neuromuscular excitement, muscle rigidity, they can be weak, they can have sluggish pupils. So sluggish pupils is when you take your pen light and go across their pupils, you're not going to see it dilate. It's going to be very slow to dilate. They could be shivering, have tremors, myoclonic jerks, they can collapse, and they can have muscle paralysis. They can also have autonomic abnormalities, so hyperthermia, tachycardia, tachypnea, hypersalivation, and diaphoresis. All right, so besides medicine, we can do other medical treatments and psychotherapy. So we can use something called electroconvulsive therapy. We can do psychotherapy. So we know that this is where we do interpersonal therapy, behavior therapy, or cognitive therapy, some type of therapy in combination with these medications. We know that this always works best. Some type of therapy with medication. So interpersonal therapy, this would work on patients that have relationship difficulties. Behavior therapy is going to be positive reinforcement of interactions. And then cognitive therapy, this is going to be where they just focus on patients that have certain cognitive distortions. And if you wanted to look in your book, table 17.5 will talk about cognitive therapy. We can do investigational treatments. There is one right now called transcranial magnetic stimulation. It's called TMS. We're going to talk a little bit more about those. So electroconvulsive therapy, or ECT therapy, this treats depression in select groups. So we usually preserve this for patients who do not respond to medication therapy through antidepressants, or to those who have very, very unpleasant side effects that they cannot tolerate. So we see this is especially true with our older adults, because we know our older adults have a lot of intolerable side effects. We can use it in pregnant women, because some of them women, because of the category of drugs, they can't take certain medications, and ECT is safe to have during pregnancy. We would use it on patients who are suicidal. Because medications, you remember when we start giving a patient medication for any kind of depressive disorder, it takes us a couple weeks to work. So if a patient is suicidal and they're talking about hurting themselves, we don't really have a couple weeks to wait for that medication to kick in. So this is why ECT is good for them. And it has a high degree of efficacy for patients with psychotic features and marked psychomotor disturbances. So if a patient does get ECT therapy, it would involve them having electrodes placed on their head. They do have some type of general anesthesia when they do this. So once they get under the anesthesia, they would have these electrodes placed on their head. Once they place them on their head, the machine will deliver electrical impulses to the brain. At that point, it would cause the patient to have a seizure, so we purposely induce a seizure. The shock will stimulate the chemistry in the brain to correct the chemical imbalance that is causing the depression. Usually, it's not just one time that they have it done. It usually happens between 6 to 15 times. That's most. That's usually what we see. It helps with the symptoms the most. So minimally 6, the max is usually 15, and they usually go 2 to 3 times a week to get the treatment. So we know psychotherapy is always combined with medication. So the goal of psychotherapy is to achieve remission. We want to have psychosocial restoration. We want to prevent relapse or any reoccurrence. We want to reduce any secondary consequences of depression, such as marital discord, any kind of occupational difficulties, and we want to increase treatment compliance. So like I said, we can have interpersonal therapy where this is where they work on relationship difficulties. So grief reactions, role disputes, role transitions, things like that. Behavior therapy is positive reinforcement of interactions. So this type of therapy would increase the frequency of the clients positively reinforcing interactions with the environment and with the intent of decreasing those negative interactions. And it's going to help these people improve their social skills. And then cognitive therapy focuses on cognitive distortions. So this is how the patient thinks about themselves, how they think about other people, how they see their future, and how they interpret their experiences. And it also helps with distorted thinking. So distorted thinking is ultimately going to influence our behavior, the way we handle situations, the way we feel about certain things, and how functional we are. And then we said that there were some investigational treatments. So TMS, which is transcranial magnetic stimulation. This is a non-invasive procedure as compared to the ECT, where that was a pretty invasive procedure. This procedure uses magnetic fields to stimulate nerve cells in our brain that will help improve symptoms of depression. They can also do magnetic seizure therapy, deep brain stimulation, and vagal nerve stimulation. So you don't have to know about those last three. I just wanted to, those are just some other things that are available, but I won't test you on them. All right, so what do we want to look for when we're assessing these people? So obviously we want to gather a great history. So we want to know a lot of detailed information about the patient. We want to hear what they have to say, but we also know that some of these patients don't have a good understanding of how things really are in their life. So the way they present things to us may not always really be the way that they are. So if there's a caregiver involved or a loved one and the patient is okay with it, we also want to get important information from them as well. With these patients, because they are depressed and they don't sleep well and they're fatigued all the time, it can be very overwhelming for them to just making it to the doctor's visit can be overwhelming to them, just actually showing up. So then to have to sit there and talk about things that have caused them to become depressed causes even more makes them feel even more overwhelmed. So you may have to take several short visits to really be able to gather all the information that you need. You want to assess the client's perception of the problem. So what do they see as, that's really causing them trouble in their life? And then we want to know, have they ever been diagnosed with depression before? Or have they ever had any symptoms previously of episodes of depression, even if they haven't been diagnosed before? So anything similar to what they're feeling right now at any other time in their life. And then if they were diagnosed with depression and they were treated, we want to know how they responded to that treatment. And then we want to look at their general appearance and their motor behavior. So when we say motor behavior, we're looking for psychomotor retardation. So really slow body movements, latency of response. So how long does it take for them to answer you when you answer them? Are their responses delayed? And then psychomotor agitation. So that would be like, so the clinical picture we would want to look at. So when they come in, how do they look? Do they make eye contact with you? Are they smiling? Do they have a flat affect? Do they appear sad? Do they appear physically ill? Are they really, really skinny? Like you can tell that they've lost a lot of weight and that they don't have good nutrition. Are they overweight? Are they euphoric? So the complete opposite end. When they sit in the chair, are they slouched over? Are they curled up in a ball, making minimal eye contact? Do they have slow body movements? Are they slow to process when they're talking to you? So you ask them a question and it takes them a good 30 or 40 seconds to respond. Or do they have agitation and anxiety? So are they sitting in the chair, wringing their hands back and forth? Are they rocking back and forth? Things like that. So then we want to look at their mood and affect. So another name for affect we use interchangeably is anhedonia. So this is, their ability to participate in things. So we want to know how the patient describes themselves. So do they use words like hopeless, helpless? Do they feel like they're down? Are they saying that they're anxious? Do they feel like they're a burden to someone or other people, or they're a failure? Do they get easily frustrated? Are they angry or upset with themselves or other people around them? So do they lose, so that anhedonia is this, are they losing any sense of pleasure from activities that they formerly enjoyed? So you would want to ask them, what do you do for pleasure? And if they say nothing, well, are there things that you used to do for pleasure that you don't do anymore? Because they might not even realize that they don't do it anymore because they're so depressed. So apathy, do they not care about themselves? Do they sit alone? So sitting alone and staring into space, being lost in thought, sitting alone, that would be more of an observation for like a milieu, if they were in some type of a community setting or an inpatient setting around other people. Obviously, if it's a one-on-one treatment, they're going to be sitting alone. They're just going to be with you. Do they interact minimally with just a few words or a gesture? So when you're talking to them and they ask you questions, you ask them questions. Are they just giving you one-word answers, simple yes or no? So you kind of want to avoid asking those yes or no questions, because you want to use open-ended questions. You want them to be able to tell you as much information as they can. Then you want to look at their thought process and their content. So do they have a slow thinking process? Maybe they're not responding verbally to the questions that you're asking them. Are they very negative or pessimistic? So do they believe that things are always going to be like this? They're always going to feel bad. Things are never going to get better. Nothing's going to help at all. You can offer a variety of different interventions and they kind of like shoot you down every single time. Do they ruminate, which is repeatedly going over the same thoughts in their head? And do they have any thoughts of dying or committing suicide? So we must, as nurses, assess suicidal ideation by asking it directly. Do you have any suicidal thoughts? Are you thinking about committing suicide, or what suicidal thoughts are you having? So definitely with these patients, this is a nursing priority. You want to ask these questions. Then we want to look at their sensorium and their intellectual processes. So we want to look at their memory, see if their memory is impaired. So are they oriented to person, time, and place? Some psychotic symptoms that they can develop may cause difficulty with orientation and cause the patient to be withdrawn from their environment. We want to look at their judgment and insight. So are they able to use their cognitive abilities to be able to solve problems or make any decisions? Some cannot make decisions or choices because of extreme apathy or their negative belief. Then we want to look at their self-concept. So this is their feeling of how they feel, if they feel worthless or if they have a good sense of worth. So in patients that have major depressive disorder, their self-concept is greatly reduced. So they often use phrases when they're talking like, I'm good for nothing, I'm just worthless, I'm not dependable for anything. These are the types of language that they're going to be using when they describe themselves. They have a belief that others would be better off without them. When patients have that thought, that's when that leads to suicidal thoughts, because they feel like eventually they become a burden to people, and that it's their only option is to not be here anymore, not only to make themselves feel better, but to try and give the people who they feel like they are also, hurting through their disorder a break as well. Roles and relationships. So we know that there is definitely a strain on relationships, personal relationships, occupational relationships with patients that have this major depressive disorder. Usually the more severe the depression, the greater the difficulty they have. So they have a lot of trouble fulfilling roles and responsibilities. So being a parent, being a child, being a caretaker, being an employee, these are all issues for them. They have problems going to school or work. They're not able to cook, clean, or care for their children. And then obviously, if you're experiencing all these issues, this is going to cause a great deal of strain in relationships. So if people can't show up and go to work every day, that's going to affect the amount of money that they bring in. So if we're talking about a married couple and the husband or the wife is the one that's experiencing this issue, what if they lose their job? Then they can't afford to pay their bills. So it's going to cause a strain, between the husband and the wife. And then once they lose their job, it's going to be even more of a strain. So it just keeps building and building and building. It's kind of a vicious circle. So there are physiological and self-care considerations. So do these patients present with pronounced weight loss because they have a lack of appetite or they just have a disinterest in eating? Are they experiencing sleep disturbances? Are they reporting a loss of sexual interest? Do they neglect their personal hygiene? So when they come, they might smell, their clothes may be dirty, they may be very unkept and unshoveled, or disheveled. One of the things that patients may complain of is constipation. And we see the constipation, one, because they're not taking in the adequate amount of food and fluid, but also because they're probably staying in bed, they're not really going out, they're not exercising. So we see that lack of activity, all the things that can cause constipation. We can give them patients' depression rating scales. So you'll see this in mental health facilities. You will also see these in primary care facilities. Primary care physicians do diagnose depression. They have these scales in their office. There's a variety of them. So along with evaluating their behavior, their thought processes that you see, their personal history, their family history, and anything that they describe that's going on situationally with these depression scales can help create a diagnostic picture of what this patient is suffering from. So there is a scale that you can give to the patient that they use to fill out. It's called the Zung Self-Rating Depression Scale and the Beck Depression Inventory. These are scales that you can give to the patient. They fill it out, and then you would look at it as the provider and kind of like make a diagnosis off of that. And then there's a clinician rating scale that the provider would look at. And that's called the Hamilton Rating Scale for Depression. So you can look in your book, box 17.1 talks about those. So some nursing diagnosis that might be appropriate for a person suffering with major depressive order. So obviously ineffective coping, risk for suicide, imbalanced nutrition. You certainly could have less than body requirements, but you also could have more than body requirements as well. Anxiety, ineffective coping is there twice, sorry. Hopelessness, ineffective role performance, self-care deficit, chronic low self-esteem, disturbed sleep pattern, and impaired social interaction. So if our patient, if we identified these risks and they were receiving some type of a therapy with medication, some of our outcome identifications would be that our patient is free from self-injury, that they would be able to independently carry out activities of daily living. So managing the checkbook, cleaning their house, going to work every day, being able to provide care for their children, cooking and cleaning, things like that. They're going to report that they're getting a good balance of rest, sleep, and activity. They will evaluate self-attributes realistically. They will report that they are socializing with friends or people within the workplace. They're going to report that they are able to go back to work or resume school activities. They're going to report that they are being compliant with taking their medication every day. And then they're also going to be able to verbalize that they have an understanding of what symptoms to look for if depression were to reoccur again. So interventions. So as the nurse, what do we want to do for these patients? Well, our first priority is that we want to make sure that they are safe. So we want to implement suicide precautions. So suicide precautions are different depending on the facility that they're in. So if you're in a mental facility that deals with suicide patients all the time, these measures are always usually implemented. So when I go to the psych unit where I work, there are things that they just always had implemented compared to if we don't have any beds on the psych unit and I have to implement suicide precautions on my unit. We have to kind of look around the room and think of things that we would want to implement. So some of the things you would want to think about are call bells. So most patients that have call bells in their room, these patients cannot have call bells because they can use it to hang themselves. So a couple years ago, it was the very first day, actually, I was orienting to charge, and we had a call bell that came to the front desk. And if a patient pulls their call bell out of the wall, it will signal to the front desk that the call bell has been pulled out of the wall. And it really takes a lot to pull that out of the wall. I mean, you really have to pull. So we got a call. The secretary was like, Trish, can you go in that room and look? their call bell's out of the wall. And I'm like, okay, that's fine. So when I went into that room, this patient had taken the call bell, wrapped it around his neck, but then all of our rooms have lifts on them. He was able to get out of bed and lower the lift. And then he connected the call bell to the lift and then raised the lift back up. So he was hanging from the lift. So this guy weighed about, I mean, he was every bit of 350 pounds probably. He was so heavy, and the cord was wrapped so high around his neck that it took like 5 of us to get the cord, to get our hands in there to get the cord out to lower him. It was actually really bad. He wound up dying. We did do CPR on him in a chair because our rooms are so small, and we were able to get a pulse back, but he was pretty much brain dead because he had suffered, he went with a while without oxygen. So he did eventually die. But so taking away those call bells, shower curtains, curtain rods they can't have. The psych units downstairs don't have any mirrors because patients could crack the mirror and take a piece of glass and cut themselves with it. What else? Forks and knives. So forks and knives and spoons. We have to give them plastic spoons to use and plastic forks. And then we have to make sure that we take them right away as soon as they're done eating. Usually we have to watch them eat and then take them. Their trays come on plastic bendable trays. What else? So we don't let them have their personal belongings. They can't have like their phone chargers, things like that. If they want to have their cell phone, we have to charge it at the nurse's station and take it back. Things like that. So those are like suicide precautions. You want to continuously assess the client's potential for suicide. So you're going to be assessing, you're going to be asking those questions every shift. Do you have any suicidal thoughts? Do you have any plans to hurt yourself or anybody else? If they say yes, then you need to know what their plan is. You want to promote a therapeutic relationship between you and the patient. So you want to avoid asking them a lot of questions. You only want to ask questions that you really need to know. So like your suicide questions, and anything else that you feel is extremely pertinent, because they get very overwhelmed with the questions that you ask them. And then we want to try and ask questions that just require only brief answers. And then we want to use silence and active listening when we're interacting with these patients. I think as providers, and just in general, we always feel like when someone tells us something terrible, we feel like we have to respond to them and say something that's going to make them feel better. Well, usually what we say isn't going to make them feel better, because 9 times out of 10, we haven't been in their shoes. So it's okay just to sit in silence with these people. It makes them feel good to know that someone's sitting with them. They can actively talk and they don't have to hear anything in response. A lot of people like that. It's very therapeutic. We want to promote ADLs and physical care. So we want to come in the morning, and instead of saying, Mr. Jones, do you want to get a shower today? Well, what do you think they're going to say to that? They're going to say no. Come in. Hi, Mr. Jones. I'm Trish. I'm going to be your nurse today. What are your goals for the day? Okay, well, at 10 o'clock, I would love for you to get a shower. That's when I'm available. I brought in your towel. I brought in a new change of socks and a gown for you. I'll be back at 10. So kind of don't give them an option. Just kind of say, this is what we're going to do, and then see how it goes from there. Encourage them to get out of bed and sit in the chair. Good hygiene, brush their teeth, all that kind of good stuff. Therapeutic communication. So we talked about that a little bit. So for them to be able to talk about that burden that they have gives them a relief. So again, that probably should have been up there under therapeutic communication. So just sitting there and listening to them can be a big help. They can get that off their chest. We obviously want to administer their medications that the doctor orders, because we know how important that is. We also want to do client and family teaching. So it's important that their family members and their friends understand that this is an illness. It's not a choice. It's not that they have a lack of willpower or motivation. They're not lazy. They're not non-compliant. This is an illness, just like cancer or anything else. So these, the client themselves and their family members need a lot of education. And then evaluating, obviously, well, we're going to make sure that they are participating in therapy and that they are compliant with their medications. All right, so bipolar disorders. Bipolar disorders are extreme mood swings that go between mania and depression. So the manic phase usually begins with a very rapid escalation of symptoms over a few days. It can last for several days, several weeks, or several months. These clients are very euphoric, grandiose, very energetic, and sleepless. They can go days without sleep and not even bat an eye, and they don't even know that they've lost sleep or recognize the fact that they need sleep. They have very poor judgment, very rapid thoughts, actions, and speech. Then the opposite of that is the depressed phase. This is where their mood, their behavior, and their thoughts are going to be the same as the people that we just talked about with that major depressive disorder. So bipolar disorder is second only to major depressive as a cause of worldwide disability. That's huge. The lifetime risk is at least 1.2% that people will develop it. Of that 1.2%, 15% will actually commit suicide. Young men early in the course of illness are at the highest risk for suicide. And it occurs most equally among men and women, but men earlier than women. And it is more common in highly educated people. So patients that have bipolar need to understand that when they are treated with medications, it's going to be for a lifetime. This is not just something that usually they recover from and they don't have to take medication anymore. Once they have it, they will have it forever. Lithium is a drug that is very effective in about 75% of patients. We can also use other anticonvulsant drugs. So you can see table 17.6 in your book. We can use these as mood stabilizers. So Tegretol, Depakote, gabapentin, Lamictal, Topamax, and oxycarbazepine. Those are the anticonvulsants that we can use as a mood stabilizer. Obviously, we're going to do psychotherapy as well. We always want to use therapy and medication together. So it is useful in mildly depressive or normal portion of that bipolar cycle. During the manic stage, the attention span is too brief that psychotherapy is not beneficial because they can't sit there and they can't participate. Combined with medication, psychotherapy combined with medication can reduce the risk of suicide and self-harm. So assessment for these patients. So obviously we want to, get that historic information. So have they ever had it before? Have they ever been diagnosed with it? Have they presented with anything similar like this before? Sometimes if they're in the manic phase, this can be difficult because they can't pay attention. So again, we might have to implement them short sessions like we did with the patients with the major depressive disorder. We want to look at their appearance as well and their motor behavior. So sometimes with these patients, their clothes can reflect that elevated mood. So they might have very brightly colored clothes. They may be extremely flamboyant. They're seeking attention, perhaps sexually suggestive. So they might be wearing short mini skirts. They might be wearing shirts that let their cleavage hang out. Their motor behavior could be very, very continuous, so they're nonstop at all, or it could be extremely slow if they're on the opposite end of that spectrum. So we do know that these patients are at an increased risk of injury and exhaustion. Exhaustion because they never stop. They just go, 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 go. Like I said, they can stay awake for days and not even bat an eye and realize that they haven't slept. And we know that sleep deprivation can be fatal. And then we're going to be looking for that pressured speech where they just completely talk like this all the time. They never take a breath in between and they just switch topics constantly and it's very, very hard for you to follow them. That's exactly how they talk. We want to look at their mood and their affect. So do they report or are they, do you see periods of euphoria, grandiosity, false sense of well-being? Do they report that they're all-knowing? Their thought process and their content. So They sometimes present with something called circumstantiality. So this is where they give an excessive amount of detail. So you may ask them about something and they will go on about it for 10 or 15 minutes. Like they give you way more information that you needed. And then tangiality. So this is where they speak about topics that are unrelated to the main topic. So you could be talking about their mood swings and then they just go off and they're talking about their grandfather's shoes, what they ate for dinner, completely off topic. And then when we look at their sensorium and their intellectual processes, so are they disoriented to time? So sometimes days go by, they'll be oriented to themselves and to where they are, but they may lose track of date because they've been up for 4 or 5 days and they have absolutely no idea what day it is. And they may claim to have abilities that they do not possess. So it could be something as minor as they might say that they're a doctor and they have a PhD, which they don't. Or it could be that they actually feel like they are a superhero and they can fly. It just depends how bad their symptoms are. So we also want to look at their judgment and their insight. So are they impulsive? Do they rarely think before they act or they speak? Most of these patients will always report that they're fine. There's nothing wrong with them. There's nothing going on. It's you, it's not me. I'm completely fine. As far as their self-concept, they will have a very exaggerated self-esteem. They'll have a false sense of well-being, which masks difficulties with really, they have a chronic low self-esteem. But they'll also have this false sense of well-being. Roles and relationships. So when they're in that manic phase, they really, really struggle to fulfill any type of role responsibility. So they will have trouble across the board, trouble at work, school, home, in relationships. They usually start tasks and they can't complete them. I should say can't. Because they can't concentrate for long. So they can't stick with any topic for any period of time. Same thing with any type of tasks that they try and do. So they might report that they have 100 unfinished projects at home. They enjoy socialization with people, but they don't recognize the impact of how overwhelming their behavior is to other people. So eventually they're going to start to lose friends. People are not going to want to be around them because they're too overwhelming. They're too flamboyant. Their self-esteem is too exaggerated and people don't want to be around that. Physiological and self-care considerations. So like I said, they can go days without sleep or food and not even realize that they're hungry or tired. They also ignore their personal hygiene. So some nursing diagnoses that we might see in these patients. Well, they're at a risk for other directed violence. They're at a risk for injury, imbalanced nutrition because they're not even going to remember that they should have eaten, so less than body requirements, ineffective coping, non-compliance, ineffective role performance, self-care deficit, chronic low self-esteem, which may be masked by that high self-esteem that they have, and then disturbed sleep pattern. That's a big one, disturbed sleep pattern and imbalanced nutrition. All right, outcome identification. So the client will not injure themselves or others. The client will establish a balance between rest, sleep, and activity. The client will establish adequate nutrition, hydration, and elimination. The client will participate in self-care activities. The client will evaluate personal qualities realistically. They will engage in socially appropriate, reality-based interactions. And the patient will be able to verbalize knowledge of his or her illness and treatment. Because remember, when they're in that phase, usually they're saying, there's nothing wrong with me. You're crazy. It's not me, it's you. There's nothing wrong with me. I'm fine. So the fact that they can verbalize the knowledge of their illness shows that their therapy and their medication is working. All right, so interventions for patients that have bipolar disorder. So providing for safety. So during this manic phase, safety is the nurse's primary focus, and for good reason. So we're going to monitor their interactions. If you're in a milieu with other people, like I said, these people become overwhelmed. They can cause other people to feel overwhelmed. Their behaviors are overwhelming to people. Their behaviors, the way that they talk, they may not always be mindful of distance between, how we talked about the appropriate distance for different types of relationships. They may invade their space, which makes other people get defensive and feel, uncomfortable. So we want to make sure that everyone is safe, the patient and other people. We want to monitor for suicidal ideations and plans to hurt others or themselves. It is the nurse's responsibility, especially in that milieu setting, to keep a safe environment for clients and others. As nurses, we need to be able to set limits and clearly identify unacceptable behaviors. And then we also want to identify the expected appropriate behaviors. So if you have a patient that's running around, getting in other clients' faces, talking to them, in a very escalated manner, you would want to walk up to them and you would say, Robert, it's not acceptable for you to talk like that and be so close to the other patients. I need you to slow down when you're talking, and I need you to back up to a comfortable distance. So you need to always reinforce what you want to see after you tell them what's unacceptable so that they have a clear understanding. We want to make sure that we're meeting their physiological needs. So these patients obviously have a hard time sleeping, so we want to have the doctor provide medication that will help them sleep. We want to decrease their stimuli, so maybe we recommend that these patients go back to their room at night and do activities in their room after 8 o'clock at night to prepare them to have sleep, so they should be by themselves. We want to make sure that they have food. So a good thing for these patients is to offer them finger foods, because if they are in this manic phase and they're constantly walking around, they aren't going to take the time to really sit down and eat a meal. But if they have like little finger sandwiches, vegetables, fruits, things like that, that they can walk around and eat, that way they're still getting their nutritional intake. Obviously, we want to encourage hygiene as well. We want to provide therapeutic communication. So we have to remember that they have these short attention spans. So when we are talking with them, we want to use clear, simple sentences when we're communicating that will be easy for them to understand. We also want to promote appropriate behavior. So we need to direct their need for movement sometimes. So if they're just constantly walking around, we want to try and use that energy in a positive way. So if you're in a milieu, have them stack chairs at the end of the night, rearrange furniture, dust things, clean things, ask them if they want to go take a walk. Manage their medications. We want to make sure we are administering them as prescribed. If a patient is taking lithium, we want to make sure that we're always encouraging at least 2 liters of water intake a day. And we want to monitor those therapeutic levels. We want to provide client and family teaching as well. So the client and the family need to understand, they need to be able to recognize these manic periods, and they need to understand what is entailed with these manic periods. What things will the patient present with? What are the detrimental effects of allowing them to continue with them? Family members need to know how to direct them. Just all the things that we talked about here, they can do at home. And then evaluation, obviously, there will not be any safety issues, right? If we're implementing what we should and the patient's taking their medicine, we want to make sure that they are taking their medication like they should, they are achieving their goals, and then the patient will be able to explain a comparison of their mood. So they're going to be able to recognize when they're feeling depressed, and then they will also be able to recognize when they start to inch towards that manic mode as well. They'll be able to recognize those behaviors. All right, so suicide is the intentional act of killing oneself. It is very, very common in people with mood disorders, especially depression. Men are at a higher rate of committing suicide. They make up approximately 72% of all the suicides are men. More than 45,000 suicides are reported in the United States every year. 2 statistics I didn't know about men and about how many people. That's a lot of people. Suicide ideation is different than suicide. This is just actually the thought about killing yourself. So active suicidal ideation is when a person thinks about it and seeks a way to commit it. So I'm thinking I can't take it anymore. I want to kill myself. What could I do? How could I do it? Passive suicidal ideation is when a person thinks about wanting to die or wishes he or she could die, but they haven't made any plan. So they really haven't thought about how they could do it. Suicide does involve some ambivalence. So when we look at like fatal accidents, they can be impulsive suicide. So if someone is killed in a car accident at a high rate of speed, they could, they really didn't think this process out. We don't know if at this point, if it's just a fatal accident or if it's an intended suicide that someone just thought about. And those are things that we actually never get an answer to. So some myths and facts, you can look, this is some good information. You guys should go to box 17.2 and read this. So these, I listed some of the myths on here. So it is a myth that people who talk about suicide never commit suicide. That's absolutely not true. Suicidal people only want to hurt themselves, not others. There's no way to help someone who wants to kill himself or herself. Do not mention the word suicide to a person you suspect to be suicidal, because this could give him or her the idea to commit suicide. That especially is not true. So some people, especially that have teenage children, will not talk about their children about these issues because they think just that. Well, I don't want to give them the idea. Well, it's more, studies show that there's more positive outcomes when you do talk about it. So if you read this this chart in your book, it's going to talk about all these myths and why they're not myths. I just wanted to put them on the slide for you. Ignoring verbal threats of suicide or challenging a person to carry out his or her suicide plans will reduce the individual's use of the behavior. Not true. And then once a suicide risk, always a suicide risk. So they are all myths. So some warning signs. So there's not a whole lot of warning signs. Some patients can send direct or indirect signals. So the nurse will never ever ignore any hint of any kind of suicidal ideation, regardless of how trivial or subtle it seems. It's not up for us to decide. If a patient says things that you don't think sound right, then you need to report it to the doctor. People contemplating suicide have ambivalent and conflicting feelings. So this isn't always a decision that they just wake up and say, I'm going to commit suicide today. This is the best decision, and they carry through with it. They go back and forth for some time. They don't want to do this. This isn't their first choice in handling their problems. It's a last choice for them. They feel like there's no other way out. Some give no warning, and then some hide their distress and their suicide plans, so you absolutely never know. But then sometimes patients will say some things like I have listed here. So they might say, I just want it all to be over. So if you have a patient that says that, you need to inquire further. Well, what do you mean by you want it all to be over? You mean you're just tired of feeling like this? You just can't wait to go home to your family? You want them to elaborate on that. So you never take these statements and just, never follow through with them. You always want to follow up. If they say, I just want to sleep and not think anymore, again, do you mean you just haven't slept for a couple of nights? You think you're going to feel better in the morning? Allow them to elaborate on that. Or if they say, you know what, you've been a really good friend to me. Well, that might be a sign that they're trying to let you know how much they appreciate your friendship, but maybe they're not going to be here anymore, and they are trying to let you know how much they appreciate you. Sometimes patients will give away things that have an extreme value to them or that meant something to them. So if a patient were to say, this is my chess set that I've had from my father when he passed away, and I really want you to have it. So that could be a sign that they're giving all their things away. They plan on not being here anymore. If they say things like, remember me, or I can't stand the pain anymore. So these are all things that you would want to inquire about. And these are things you want to educate the family members about as well, because they need to be able to recognize these symptoms and inquire further. But then you also have these patients that you never even knew. They just suffer in silence. They always have a smile on their face. They never complain about any problems. And it just comes, out of the clear blue with no warning at all whatsoever. All right, so assessment wise, so we always want to ask, do you have a history of any suicide attempts? The first 2 years after a person commits suicide, they are at a much higher risk of committing suicide again, especially within the first 3 months. So have you ever committed suicide before? Or, have you ever attempted suicide before? In families where there's been a relative that has committed suicide, the risk is always going to be much higher. The closer that person was to that person who committed suicide, the higher the risk is for that individual. Relatives, so when they have if you're dealing with a person who had a relative, so maybe they had a brother who committed suicide, that almost kind of makes it easier for them to commit suicide because there's this acceptance, almost like they're getting permission. Well, my brother did it and my family is okay today, or we've all been okay. I can do this as well. So warning of suicidal intent. So like I said before, when we were talking about antidepressants, some patients that are really depressed don't even have the energy to implement suicide plans. So they think about it, it's an option, they have a plan, but they're too exhausted mentally and physically to actually carry through with the plans. As far as different time periods of the year, we do see that most suicides occur in April. And the theory behind that is that natural energy accompanies that increase in sunlight and warmer weather in the spring. So that's why these people have more energy and then they are able to act on their suicide plans. Most suicides happen on Monday mornings. I didn't know this either, when most people return to work. Actually, it's just like another energy spurt for them. And then we know that when patients start an antidepressant therapy, any kind of antidepressant treatment, it actually gives them the energy they need then once they start to feel better to act on that suicidal ideation. And then any kind of risky behavior. So some patients will participate in something called Russian roulette. So they want to commit suicide, but they almost want there to be some other, not another power, but they want there to be something else that decides whether or not they are able to commit suicide or not. So they don't want the whole decision to be on themselves. So they may put, just one bullet in the gun and, take their chance. And if they hold it up to their head and it's the bullet, then it was meant to be. And if there is no bullet comes out, then that's kind of like in their mind, they feel like, okay, it wasn't meant to be, so I probably shouldn't be committing suicide. So when a patient talks about committing suicide, we have to follow up. So we have to say, do you have a plan? And if the patient says yes, what is it? And is the plan specific? So you want to know as specific as possible what their plan is. Do they have the means to carry out the plan? So if the patient says, well, I'm just going to take my life by a shotgun, well, does he have access to a gun and ammunition? These are things you need to know. If the client carries out the plan, is it likely to be lethal? So if the patient says, I'm just going to take 10 aspirin, I'm going to commit suicide. Well, you might bleed to death, or you might bleed for a long time, but you're probably not going to die. While a plan to take a 2-week supply of their, antidepressants, those TCAs, that absolutely would be lethal. Has the client made preparations for death? So are they giving away their prized possessions? Have they written a suicide note? Or are they talking to friends one last time? We want to know where and when does the client intend to carry out their plan, and is the intended time a special date or an anniversary that has meaning to the client? So did they lose a loved one on a certain day? Were they married and their husband or wife left them on this date? Those can be triggers for patients. And then specific and positive answers to these questions all increase the client's likelihood of committing suicide. So it is extremely important to consider whether the client believes his or her method is lethal or not. Believing that a method to be lethal possesses a highly significant risk of being able to follow through. All right, some outcome identification examples. So they will be safe from harming themselves and others. We can have them sign a no suicide contract, and that's exactly what that is, that they agree not to hurt themselves and that they will do X, Y, and Z when they feel a certain way. We give them kind of like a plan to be able to handle themselves, who they can contact, what should they do when these thoughts come about. The client will be safe, again, from harming themselves or others. The client will engage in therapeutic relationships with families, with their therapist, going to treatment each week. They will establish that no suicide contract. I'm sorry, I don't know why these are listed twice on here. The client will create a list of positive attributes. So we want them to be able to, these patients think a lot of negative things about themselves. So we want to help them do the opposite and make a list of all the positive attributes that they possess. And eventually over therapy, hopefully that positive list grows to be larger than the negative side. The client will generate, test, and evaluate realistic plans to address their underlying issues, and they will be able to list positive attributes. That's listed twice again, sorry. All right, so intervention. So we know that intervening is the first priority of nursing care. We do not want our patients to actually follow through and commit suicide. So the nurse lets the client know that their safety is their primary concern, and it's going to take precedence over any other needs or wishes of themselves or anybody else. So the patient may say, I need to go to the bathroom, I'm hungry, I'm this, I'm that. No, my first priority is going to be maintaining your safety first and foremost. You want to use an authoritative role. You have to be you have to be in charge in this situation, because you as the nurse have to make sure that this patient is safe. So we want to do all those things that we talked about a couple slides back, providing that safe environment. And there's a couple things listed on here I didn't mention. So we don't want them to have access to their own medications, but we want to make sure that we are administering their medications that they have. You don't want to keep any type of materials used for cleaning or anything like that sitting out in the milieu or around the patient. Sharp scissors, needles, things like that we would use just as nurses. You don't want to have them on you or around you. They should be locked in another room. No access to pens, knives, obviously, call bells, shower curtains, phone chargers, and then personal belongings. And you want to create a support system list. So these patients don't always have a good social support system, or they feel like they don't have one. So we want to create a good system for them so they know how to cope and who that they can depend on the outside. So the nurse is going to assess for whether or not they have support systems, and the type of help that each person or group can give a client. So if they have, their mom is coming in to help them with treatment, or maybe a sister or a brother, not everybody can show up for the person in the same way. So you kind of want to set a plan and put it in writing as to when they could contact this person, what they're able to help them with. Well, if you feel like this, give me a call and we can do this. Or if you're feeling this, then you should call your mom because she's more available for you during these times than I am, that kind of stuff. So family response. So these patients, when they commit suicide, this is the ultimate rejection of their family and their friends. So suicide is going to send a message to others that their help was incompetent, irrelevant, or unwelcome. It is done sometimes because the patients want to place a blame on a certain person, even to the point of planning how that person will be the one to discover the body. So an example of that would be if maybe, I don't know, there's a mother and a daughter, older adults, live together, and they had just a terrible, horrible relationship. They felt like the mother never really was able to show up for the adult child. She could never depend on her mother. They had a terrible relationship. The child may commit suicide at home, and knowing that the mother would be the one who would find her. So they do it to finally in some ways they're kind of getting like a last dig in against the patient, against the loved one, kind of like a final say in their relationship. And most of the time when they do commit suicide, their efforts are to escape untenable situations. So they don't see a way out of whatever situation that they're in. Families will react with guilt, shame, or anger. So this comes from them not knowing how desperate the suicidal person was, not knowing that they suffered at all, that they had any type of issue. They often wonder, why didn't they seek help from me? Why didn't they trust me? So then that person then evaluates how they were with that person. And then they start to feel guilty. Well, I didn't show up for them. I didn't give them enough love growing up. I should have showed up more. I should have done this. I should have done that. They're ashamed. Some people are ashamed that their loved one ended their life. It's an embarrassment to them because it is seen as something that's socially unacceptable. And then sometimes these people are left to feel sad because they were rejected by this person. And then obviously suicides can cause a family to disintegrate. So those loved ones that are left behind can have a lot of trouble coping and moving forward. And it's very common to see certain family members distance from each other. It does result in a high divorce rate in some instances. So the nurse's response, so these patients need unconditional positive regard for themselves. These patients are in a desperate emotional state. So we need to understand that as a nurse. We need to avoid blaming the client. So the client already feels like they're incompetent, they're worthless, they don't have any hope left, they're helpless, they don't have any control over their situation. Dying is the only way out. So we don't want to add to that and make them feel guilty. We never want to speak with them in a judgmental tone or approach them in a judgmental way. They are very intuitive. They can monitor our behavior and our language and our facial expressions. So we need to be very aware. The belief that one person can make a difference in another person's life. So nurses must convey that people can be helped and can grow and change. So we always want to encourage that in that person. We always want to let them know that there is help, that they can change, that they have to see past today. So we really want to be positive with them. And then possible devastation of the staff if the client commits suicide. So obviously, if this happens to one of your patients, there's a lot of different things. So you probably had an established relationship with this patient, and it's going to be devastating for you. It's going to be devastating for the people around you that you worked with that also cared for this patient. And if you've gotten to know the patient and they had an involved family, you probably know the family members too. So you're mourning for their loss as well as yours. Staff, we may need therapy. You may need time off of work. Some people are never able to come back from something like this and they leave altogether. So it affects everyone. So some legal and ethical considerations. So assisted suicide, this is not something that we've talked about yet in any of our classes, but this is a very talked about topic in our nation. It's a very ethical debate. I'm sure most of you have probably heard about Dr. Kevorkian. He is a physician who has participated in numerous assisted suicides. So he helps people take their own lives. Oregon was the very first state to adopt assisted suicide into law. I'm not 100% sure, but I think that there are a couple other states, but I'm not sure. Obviously, there are varying beliefs surrounding this. So healthcare professionals or families should be able to assist those who are terminally ill and want to die. A lot of people think that. Other people think that against the laws of humanity and religion and belief that healthcare professionals should be prosecuted if they assist those trying to die. So two sides of the spectrum there. Nurses often care for terminally or chronically ill people with a poor quality of life. So you need to have a sense of self-awareness when you go into certain job fields. So oncology is always the field that comes to mind because that's where I worked. It can be very hard for you to watch people die or to be terminally ill. It can be draining mentally, and it can have physical disadvantages as well over time. It is ultimately, it's not our role to decide how long these clients suffer. It's ultimately up to the patient. So we always have to know that that is not part of our nursing role. And if it's something that you feel like you cannot deal with, then it's probably not the type of field that you should be in. And the nurse's role is just to provide supportive care for our patients and their family members as they work through making various decisions in that process. So elderly considerations. So depression is very, very common among the elderly, especially when they're medically ill. Psychotic features are more frequent in younger people with depression than older people. We do see an increased intolerance of side effects of medications, which leads to they can't tolerate doses higher enough to be therapeutic. ECT therapy is more commonly used for treatment because we get that more rapid response in elderly people, and suicide is increased among the elderly. And it leads because they have the most rapid response to treatment. They must have the most rapid response to treatment, and we don't always get that with the medications. All right, so community-based care. Nurses are the first healthcare professionals that are able to usually recognize behaviors consistent with mood disorders. So usually in the community setting, if we're doing home-based care, we're seeing these patients on a pretty frequent basis, depending on what we're seeing them for. You know, where they are in their treatment, we could be seeing them 2 to 3 times a week. We could be seeing them once a week. It just depends where they are in their treatment. So we're seeing them on a regular basis. So we are more apt to notice these changes in those behaviors. Also, if we are dealing with family members as well, they're able to give us information about their eating patterns, their sleeping patterns, if they're withdrawing from activities, if they exhibit these manic, these manic phases. We want to make sure that we are documenting and reported behaviors so that these patients can get the treatment that they need. Nearly 40% of people who have been diagnosed with a mood disorder do not receive treatment for a variety of reasons. 2 of the most common reasons are because there's a very large stigma that surrounds mental health issues. People are embarrassed to talk about it. Some people don't want to admit that they have it. It's embarrassing. And then because we lack community resources to be able to handle these individuals. Successful treatment of depression in the community can be done by psychiatrists, psychiatric advanced practice nurses, and primary care physicians. So we do see a big, I told you earlier that people can be diagnosed with depression and anxiety in primary care offices. People with bipolar disorders, however, should always be referred to a psychiatrist or a psychiatric advanced practice nurse. So someone that really specializes, because there's more components to that than there is just the depression or the anxiety. So that's better managed with someone who actually handles that as a specialty. And then mental health promotion. So we want to make sure that we are giving them education to address the stressors in their life that can contribute to them developing depression. So we want to focus on really increasing their self-esteem and reducing loneliness and hopelessness. Efforts to improve primary care treatment of depression. So we want to focus on improved screening, evidence-based protocols, patient self-management, stress therapy, developing a crisis plan, creating a social network, making needed behavioral changes. So these are all things that we can work on in that primary care setting. And then prevention and early detection, treatment for adolescents. Suicide is a leading cause of death among adolescents. So, and make sure that parents are taking their children for their physicals every year, so that those primary care offices can follow up on these issues. And then strengthening those protective factors. So those protective factors are having close parent-child relationships, making sure that they're doing well in school. Do they have a good family stability at home, you know, a mom or a dad, or maybe not a mom and a dad anymore, but maybe two moms or two dads, or just a stable family environment, and connectedness with peers and others outside the house. And single parents also can provide stability for parents. I shouldn't have said just two parent homes. Single parents can do a great job of providing an adequate stability for their children. So we want to make sure that there is screening for early detection of risk factors. We want to identify any type of family issues that we see, parental alcoholism or mental illness in the family. We know that those can cause issues. Is there a history of fighting in the family, access to weapons in the home, or is there any bullying or cyberbullying? So this is definitely something that we see nowadays. This does require, however, a joint effort of parents, families, and schools. It takes the involvement of a lot of people. And then lastly, we always have self-awareness issues. So we have to know the importance of dealing with our own feelings about suicide. We have to understand that there is always the possibility of becoming frustrated when we work with depressed or manic clients, because it can take a very long time before we see a change in them. And as nurses, we kind of want to fix people, because that's why we become nurses. We want to help people. So sometimes we're always looking for that, you know, that instant gratification, and you don't always get that in the mental health field. Exhaustion when working with these manic clients. So I can relate to that. You know, I don't work on a psych unit, but I take care of psych patients sometimes, and I do float there. And just dealing with those emotional issues and the manipulation and the behaviors that go around that is just mentally exhausting. And like at the end of the day, sometimes I feel like I don't even want to talk to my husband when I come home. I'm just mentally drained. So if you're doing that and you're working in that setting all the time, you really need to understand that that is a high probability of, you know, working in that job. You can journal to help deal with your feelings. Talk about colleagues is often very helpful, which I feel like that usually happens in the workplace. And then just that self-reflection. When you're driving home at night, turn off the radio, think about your day, things like that. All right. That is the end of